how they been positioned. They have been positioned in 146 districts and cities. Okay? And out of the 146 districts, okay? Yes. In the 146 districts, there are 357 constituencies. And that will define how many community hospitals we will have. But when you break it down to counties, there are 312 counties. If you break it down to sub-counties, there are 2,184. If you break it down to parishes, there are 10,595 parishes. How about villages? You come close to 70,000 villages in Uganda. Okay? This according to our political and administrative structures. Now, you can draw out from these structures I've mentioned communities which are called organized communities, which are found in those either districts or constituencies we are talking about, but you can also draw out what we call individual communities. Now, the one we describe as individual communities are actually the individual households. And remember, households can be of just one person. It's a household. But a household can be of very many members. We can call them families. And aggregation of those households will form villages. But remember, I've said, from these administrative structures I've told you can grow out individual communities, but you can also grow out and form organized communities. Now, from these organized communities, you have institutions like refugee settlements, you have institutions like schools, you have places like marketplaces, church institutions or church communities or religious communities. You have workplaces. These are organized communities. You will go and find that they are really organized. If you look at some religious communities, they have even schools of their own. They even have facilities, health facilities of their own. Organized communities like refugee settlements. We keep trying here that why do they have the best facility in terms of health service delivery? Yes, most of the facilities are very organized because they are structured. But also remember, if you have your individual communities, the household we are talking about, you can put them together and they can also form organized communities in form of, like we saw the women associations or the circles, or the people with disability, the youth groups, the border, all can come out from that household. So, again, draw your attention to these preventive services, which is going to be my example all the time. If you look at these communities, what makes it difficult for us to reach them wherever they are with this kind of preventive services? Okay? But that said, continue. That slide you have seen is the one I was referring to. Continue. Now that is the scope and target of who we are calling our community. Okay? You have seen the organized communities and you have seen the individual communities. And out of those household communities, you can aggregate them and they can form even organized communities like I'm saying. But they can also form what we call those associations, those youth groups, those landlords, okay? That is the community we are talking about, okay? And there are certain communities within there which are very, very close, which even Your VHT cannot reach them. Which people your extension workers, the one who are called community extension, cannot reach them. I was being educated by one eminent person that me who is a good user of this one, I can reach them. Okay? Me, I can reach them because I can be one of their clients. Okay? And they are very close. So what am I trying to say? I'm trying to say that in delivering this service, we may need a whole of society approach. A whole of society approach. Go to the next slide. Go to the next slide, and that is the slide I want to dwell myself on. That's the conceptual framework for the national health system we are now trying to implement in this country. If you look at those red boxes represents the original WHO system building blocks. Okay? But later on, when we say we needed to reach everybody within the comfort of their homes and give them the services they want, it was imperative that we needed another arm. We cannot do that only depending on facilities. We needed a community platform. And so, what came out in the first box there where you see service delivery, what came out there is let's get service delivery packages which can address the needs of our communities. And that's why you see the grid which is embedded in the service delivery box. But also we said, if you need to continue with that assisting blocks of WHO so that it can deliver to the community, you now need to embed what we call now the community-based, trained health workers. Okay? Community-based trained health workers. Now, those are not my slides. I borrowed that slide from the National Health Policy. Now, if you do that, then you have the capacity to do one thing. Come out with what we call household production of health. That's the kind of service package we're talking about, to create demands at household. But who should deliver them? You need that workforce, and so you need community and organizations, okay, including community health volunteers. But you need society partnership in order for you to be able to create healthy population, healthy community that can contribute to socio-economic development of this country. And that's where PDM becomes crucial. A community that is healthy, that can contribute. And we think the people we ignore at the home, at the household level, we ignore them, we think they cannot contribute. But if we empower them, we retool them, we also bring them in the communal space, and they start producing because they are healthy. They can contribute. And that's why PDM comes in healthy. But PDM has only shown you the small trick of just bringing the community to the space by using that pillar number 3, financial inclusion. That's why people are blind there. We should follow them without pillar number 4, which is social services. That's the essence and the irony behind that service delivery. Now you can continue to the next slide. That slide there, I wish you can read it very well. That is the slide which is at the center of my heart. I picked it again from International Essential Package 2024. You can see that it talks about the structure of Uganda healthcare delivery system. The system which is going to deliver for you the essential package that I've been talking about. And it is divided into two. Those ones which are made in colors, they were made sexy because they wanted to attract you and talk about those regional hospitals, those national hospitals. Those are the central level and affiliated institutions. That is where they are. And I'm not going to touch them. They are represented here by the hospital directors, by the executive directors of some institutions out there. But the point I want to make to them is, even at that level, we need to think about creating a community health department in the institutions. Because you need them. Those facilities are sitting in a village somewhere, they are sitting in a village somewhere. They must have the community there as well. I hope I am communicating. But those ones which are left in the gray, the local government health system, the individuals are here, they never talk about it. They keep asking, what is the sustainability of this program? But you have the whole system of health service delivery here. Okay? Ranging from what now we are going to go to mini hospitals. Okay? We are going to have, health centers. We are going to have health centers at parish level. If you further those health centers, we are left with the tools. Okay? Then we have at the village. Now, at the village is where we have the village, we have the hospital, we have the schools, we have the workplace. Are we talking now? That is the local government health system. Okay? At that system, at that lower level system, we are also working in the private sector, the public hospitals, the private hospitals, the private pharmacies, level 2 laboratories, and actually including level 1, including the rehabilitation centers which are private. We have also private maternity homes, level 1 laboratories, clinics, and workshops. The players at the village level there, like you can say, include the village health and other community health workers, including institutional clinics. Does that make us short in the workforce? We just need to optimize the use of this program. Okay? And deploy them appropriately and correctly to deliver, push us to the next slide, to deliver the kind of service delivery package we are talking about. That is the service package which my commissioner, Dr. Sarah, and that is the one we are passionate about. The service package which talks about health promotion, it talks about disease prevention, and talks about community health initiatives. Okay? And those are the breakdown of what falls under that cluster 1. But I showed us even in cluster 2. There are components that go to the community. Cluster 3, components that go to the community. Cluster 4, including cluster 7, which is veterinary level of healthcare. Now, don't ask me that in English. Yes. And so, go to the next slide. That one we're going to run. We're not going to go to the we are all given us by Dr. Sarah to see how huge that service package is. I'm going to tell you this because I want to be appreciated. That the two very team of our village cannot manage. The two tools of our parish cannot manage. Continue to the next slide. Okay? The 10 that service package. Community workers and the that cannot manage. Go to the next slide. All this is for community. Go to the next slide. Stop there. Now, when you stop there, that particular bit of the cluster 1, that is our clusters, is talking about disaster management and response. Okay? And the level of delivery is community, local government, Ministry of Health, Office of the Prime Minister, the national level, and the other group is all of us. All of society approach. Because not one of the people collaboration in structure level 1, which is the villages, cannot manage all this. The ones I mentioned at level 2, which is the cannot free. Sub-account, they cannot manage alone. Okay? Occupational health and safety. That's the workplace wellness program. We have seen how people are trying to describe their wellness program. Okay? They are only thinking that dancing and managing the wellness program. Okay? Wellness is talking about the definition of health. Health is not just absence of disease. Okay? Yes. It's a complete state of health, isn't it? Yes. And that will have to make it worse by bringing another indicator of disability which we don't see. And you will see all of us, I think, we are well when we are not well. And that definition says if you have never had a partner, for the last one is a disability group. I don't know what you are describing here. You can handle that. Let's go to the next slide. And I want to read for you that particular slide. It's also from the National Sexual Health Package 2024. It's about cluster 1, how we want to deliver that cluster 1, it reads accountability for property. This cluster has maintained a focus on health promotion, disease prevention, and community initiatives. As noted in the background section, Uganda still has a high burden of preventable illnesses that imposes high treatment costs on already constrained resources. It is estimated that 60% of the mortality in Uganda is due to preventable conditions. Therefore, initiatives geared at addressing the social determinants of health and giving relevance to poor health and promoting health lifestyles are critical. This problem is being addressed through promoting health education and health promotion as well as a multi-sectoral implementation of key strategies by multiple stakeholders that include communities themselves, the religious leaders, the private sector, and other key sectors such as education, transport, gender, housing and urban development, agriculture, water and environment, works and transport, etc., 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 and of thinking capacity. And the intervention in this cluster also addresses the emerging health threats, including air pollution and including climate change and emerging diseases such as Ebola, Marburg, COVID-19. Let me to the next slide. That is now where I'm going to address myself to. How do we then deliver this package? Cluster 1, which is health promotion, disease prevention, community initiative. We are saying, but I want to optimize it to scale and also deployment of these community workers can help us achieve milestones. And we are talking about community workers who are both formal and non-formal. And when we read in the multi-sectoral layers, then we talk about the whole of society approach. In this whole of society approach, we are looking at other community workers, which include community themselves, the religious leaders, the cultural leaders. We are talking about the private sector where we have the private facilities, and the hospitals and pharmacies, which are private, level 1 and level 2 laboratories, which are private. We are talking about rehabilitation centers, private maternity homes, clinics, drug shops, which are never mentioned anywhere. Okay? But we also bring into the space the civil society organizations, the community-based organizations, line ministry department and agencies like education and sports. We are talking about gender, water and environment, works and transport, housing and urban development, etc., etc., including institutions like schools, workplaces, markets. Mention them. Those are the kind of workforce we want to optimize so that we can achieve the delivery of that service package. Take me to the next slide. That next slide gives you again that particular picture to draw your attention of how we want to trigger the local government health system to start functioning. You have the resources, you have the workforce, you are actually already working. What we want you is to start thinking community health. You have been only thinking facility-based service delivery in your facilities. In the morning, Dr. Sarabia Kita Commissioner Planning said they have given you 30% of your budget to do those activities in form of outreaches, in form of camps, in form of campaigns, okay? It's not just for only health talks over radio, which health talks over radio, the RDC already has enough money for you for free, so you can spare the 30%. Okay? Yes. So, the workforce I'm talking about, as for establishment and structure, take me to the next slide. Next slide, please. Yes, there we are. The formal ones are on this side, and we are looking at Health Center 4, that they are 13. At Health Center 3, they are 10. At Health Center 2, they are 0, 0. Health Center 1, they are 0, 0. But when we look at the non-formal, we have at Health Center 2, 2 per parish. At Health Center 1, 2 per village. But also know that those 2 per village are attached to either Health Center 3 or Health Center 4. Within the villages they are working, if the facility lies there. Those 2 per parish are also attached to Health Center 3 or Health Center 4 in the parishes where they are working. So they are not just hanging out there on their own. They are attached to facilities so that they can be supported to reach the household they are serving. Okay? The medical we are talking about, there are those ones who are medical and there are those ones who are non-medical. Again, I will make this very clear for you because you are thinking it's a myth. Take me to the next slide. Now that next slide, I have given you some handouts there. I want you to look through page for page. And I'm not going to build myself there. I summarized them and told you, according to this approved structure, which is posted and given out, okay, it's telling you how many non-medical and how many medical community health workers are attached to the center for. Take me to the next slide. Still around Health Center 4, non-medical and medical. You have the paper in your hand. Continue to the next slide. Yes, still Health Center 4. Okay? Non-medical and medical. Continue. That is the end of Health Center 4. Okay? Look at how much money if you add, if you can take those ones you think are the medical and those who are the non-medical but they are community health workers. See how much money we have tapped against them. And that's why somebody was asking, where are the people from Ministry of Finance? Because Ministry of Public Service has done their part. Also Ministry of Health has done their part. Now it is Ministry of Local Government, VHOs, you with your Ministry of Finance, get that money. They are approved. Okay? Next slide. Now that starts Health Center 3. Approved, costed structure for Health Center 3. Medical and non-medical. Next slide. That is the end for Health Center 3. In Health Center 3, I have counted, I have found there are like 10 for health center 3 and accounted for health center 4, they are like 13. But that depends on my understanding. The DHOs who are here will help us. Who are they? Are they at 13 or more than 13? Because also the DHOs are themselves community health leaders. Yes. And that's why for me, at the Ministry of Health, sometimes they call me chairman. But not chairman of DP block, but chairman for local council 1, that I have the village health care. Okay? So, take me to the next slide. That's how we are prepared. We are prepared by level. At Health Center 4, we have the Senior Environmental Health Officer, social workers, sign language interpreters, epidemiologists, environmental health officers, vector control officers, health educators, assistant nutritionists. We have health inspectors, public health dental officers, assistant nursing officer, public health, and nursing officer, public health. All those are at Health Center 4. All those huge salaries I told you to calculate goes for them to do what is supposed to be community health. Yes, by the definition and job description of their employment. At Health Center 3, I found their counselors, assistant nursing officer, public health, assistant health educator, assistant vector control officer, health inspector, sign language interpreter, health assistants. They are all there at Health Center 3. Go to parish level, 2 per parish. Village level, 2 per village. Then at that village level, you have also other community health workers supported by partners, civil society, community-based organizations, other MDAs who want to align themselves with the PDM. How prepared are we? Now, that handout given to you, I want you to read it, and I want us to read together. Turn to it. Those ones who have it. It's not a gospel according to Dr. Pinto, but I'm going to tell you who gave it. Next slide. Take me to the next slide. Continue. That is going to be our deployment plan and readiness. Continue. That is how prepared we are. We got that approval for public service, and public service wrote this letter, which is not a secret document, it's a public document. It was dated 5th of April 2023 to all chief administrative officers of district local government. Reasons: you now have district local government health system. It is a approved structure for Health Center 4 and Health Center 3. Reference is made to the letter from the Ministry of Health. Reference AD dated 25th of February 2023, communicating the recommended structure for different health facilities. The submission of the recommended generic structures by Ministry of Health for Health Center 4 and Health Center 3, and the attendant request to approve them for implementation in the phased manner has been noted. The structure have been analyzed to ascertain compliance with attendant guidelines for restructuring and reporting relationship for government institutions. The purpose of this letter is to communicate to you the attached approved generic structure for Health Center 4 and Health Center 3 for implementation, not for anything, but for implementation within the available wage provisions for the financial year 2022-2023. We are now in 2023-2024. You are not up for your share. And you are asking me, what is the sustainability of this? Next slide. District health system as a multi-hub model. We showed you the facility catchment area approach, with the DHO office sitting on top planning for all the facilities under them, for the facility to be able to reach the household. And this hub and spoke model will become clear tomorrow when the regional river hospitals come to teach us how they understand the hub and spoke model. Next slide. And when we talk about this facility as a hub, we know that this facility, whether it is Health Center 2, whether Health Center 3, Health Center 4, to which these community health workers we are looking at as they choose or the VHTs, they are attached to this facility, which has a number of human resource persons employed there. They also receive medicines and supplies from the Ministry of Health through National Medical Store. They also have PSC fund, which comes from Ministry of Finance. They have the managerial capability to plan, to coordinate, to deliver services. And these services which they can plan for, to deliver, can be services which are already inside their facilities, but they want to extend it outside of the facility. Okay? But they can be services they want to hand over to, they choose to run with it. But they can also be services they want to hand over to the village health team to run with it. Because we know the village health team on a daily basis must be at household. They choose every 2 days of the week, they must be into the facility, into the villages, doing some work there. They are at the parish level. Okay? So as the facilities are planning, the district health office is helping them to accomplish their work plans. They are thinking through how can we do camps, how can we do outreaches, how can we do mass campaigns, how can we do scheduled home visits for those ones who are going to be referred to us or given to us by village health teams, so that we don't miss out on whatever service they want to receive. Okay? And some of the services have been demonstrated already by people who are actually seated at the Ministry of Health in the quarter, which want now the district themselves with their facility to take over. Take over ICCM, take over CAST Plus, take over integrated child health days, take over mass immunization campaigns. What is difficult there? Do you need to really continue to sit and wait? Ministry of Health to climb from up there and come down to the facility, down to the districts, and do all this with all the capability now you have. You are going to ask me questions starting now. I rest my case. Thank you.
So thank you very much, Commissioner. Commissioner, you can have a seat. That was a very comprehensive presentation. We saw how he was showing us some of the things we use in communities. But without wasting time, we are going to have the second presentation from still a former DHO. He's a former DHO, currently Commissioner, HRD, that's Human Resource Development. You will also guide me with the title. It has some I, Dr. Joanne Alfred. And thereafter, I will invite the chair of the panel, which will be our last panel. So Dr. Joanne can take it.
I want to be as crazy as a musician in this presentation. And when I was young, I went to a disco place, a show, and I saw the musician. He would make a statement and does like this. People complete that statement. Then at some point, they throw themselves at the crowd. The crowd is the one who calls. So I'm going to be as crazy as that. is made at home. Health is made at home. It is the responsibility of
everyone.
So this is the problem of having a young population in a country. They forget quickly. When we joined the service, there was a statement which was made by the Director General then, Dr. Maswa, that health is made at home. It is only repaired in health facilities when it breaks down. It is the responsibility of individuals, families, and communities to do what is right to keep healthy, feed well, keep clean, do not share accommodation with animals. So we think we are so modern that we don't want to go that route. Even if we have been singing the national anthem for the last 60-some years without changing the stanzas, but we are changing the stanzas for health promotion and community health interventions. And we will pay dearly for this arrogance. And I would like to challenge any partner who has some resources, whether we can get an updated version of this message and make it run as the flagship messaging for community health programming. Are we on the same page? I've disappointed them. Are we on the same page? All right. Now, the second, my presentation was already finished by my senior brother. But I would like to summarize my task on the program by saying that we have started a big and a long journey. No quick fixes. Often we think that community health is a cheaper option to expensive clinical care. I just want to say it is not, because the inputs required are very expensive. And the gap I'm going to demonstrate will only tell you the business ahead of us. So I am my former Health Center 3 in charge. I'm a former Health Center 4 in charge. I'm a former medical superintendent. I'm a former health sub-district in charge. I'm a former district health officer. I'm a former program manager of immunization, and I'm aspiring commissioner for institutional capacity development. So that's what we do. It's not the purpose of this presentation. My new work will be to look at see in the center there, the performance of health institutions, performance of the health system, and the skills sets and performance of healthcare workers. And therefore, the entry of my work is to review and see if we have gaps. This can come from academia, it can come from analysis. It will provide evidence for our policies guidelines. We have the Commissioner for Policies. She will serve herself from that menu. And for me, I will make it an issue. Also, some of them will feed into our planning process, advocacy for budgeting, resource mobilization, capacity building of health workforce and change management, performance reports, and then it feeds back into governance. That's what I'll be doing. So my relationship with the universities is becoming very interesting, And I'm also spending a lot of time reading evaluations and things like that. Next slide. We must look backwards in order to drive the health system forward. That is what is read down there. Study history, study the past. 54 years we are coming to the realization that for primary health care to work, we must invest in structures, we must invest in people, we must invest in enabling policies. What we are doing here should have been done that time. We have been doing primary health care lip service, now the time has come. Never too late, but we must do it, and let's do it properly. From Alma Ata. Next. This is no news to anybody. Health being a complete state of physical, mental, and social being, and not merely the absence of disease or infirmity. So you can see how broad it is. Next slide. With its broadness, health is also a human right. I think we start, as healthcare workers, we start becoming sober when we start putting on different lenses. These are things we were not taught in medical school. Now we're in the field, we need to grow up and mature and understanding some of these things beyond our domain. Human rights are things given to us by God because we're humans, and nobody is supposed to take them away from us. Governments have an obligation to promote it, to defend it, to protect it, and defend it. So that is life, that is safety from abuse, exploitation, safe water, education and health and health services, education and information, shelter, and food. Broader. But let's zoom in, we will zoom in on health specifically. Next slide. Since it is a right, that small boy there is a claim holder. So when you hear people complaining, now this to my DHOs, when you see the public complaining that midwives are rude, that's a common complaint. I have nothing against midwives. The health workers come late. They are doing the right thing. Otherwise, how are they supposed to claim their right? They are just saying it is hurting here. Opapachi. Opapachi. So that small boy is claiming his right. Next. We in the health sector were duty bearers. Next. And we have obligations to it. So the service is entrusted in us, in our hands. There are obligations we must deliver. So when you are in a facility and the people are complaining, you're coming late, don't play Jesus. You have an obligation. Next. You will be held accountable for that obligation. Next. Between your obligation and at the time of accountability, there is always a gap. So ours is to work on the gaps. When the people are complaining, by actually doing situational analysis, pick the issue out of that complaint. Next. And that gap capacity is my job now, officially. It informs the programming. Next. And once our programs are designed in a way that are responsive to the people's needs, we meet our obligation, we perform our roles, we become happy because we are achieving what we are existing for, and the small boy will put a smile on his face. So when we are talking community health, I am hearing like we are beginning to talk about ourselves, our organizations, our responsibilities. At the end of the day, the purpose of this slide is, it starts with the miserable boy and it ends with the boy. Am I sounding like a pastor? Okay, next. Accountability, you can be held accountable through the law. Next. Society can also judge you. Remember, for those of you who work in your own districts, whatever you are doing, you are writing the speech for your funeral. What they will be saying at the funeral is what you are doing. Okay. Next. Now, when we are also talking about community health services, my brother whose name sounds like the sound of a big gun, Dukum. For those of you who have not lived in the war areas, you may not understand some of these things. So, Dugum has talked about services which are provided to people. I love this picture. Even the man who did it is called the Whitehead. I didn't know I would be having a whitehead. I've been using this slide now for the last, I don't know how many years, 15, 18 years. The determinants of health are the things we are supposed to address through community health interventions. The determinants of health. Now, for us to intervene properly, we need to work with people beyond the health sector. That's why it is not a very simple business. For example, who is disorganizing my slides? You know now, once this goes off, the presentation ends. I cannot talk all this off-head. So look at the general socio-economic, cultural, environmental conditions determine whether we'll be healthy or not. I worked in another country where the mining areas were not managed very well. All men were coming with something eating their scrota. It became a big issue. Determinants of health, the environment was not managed very well. We talk of genital mutilation. That's a cultural practice which determines health. Poverty. Ugandans say they are poor because of, others say they are poor because of ill health. So the interrelationship between poverty and health speaks for itself. But look at the green zone. Agriculture and food production will determine health. In Karamoja Pande, Dr. Pande, in Karamoja, when there is prolonged drought, what happens? Your wards become full. When they die, they are your problem. But the journey started where? From production. So, you think as health, you will address nutrition without bringing the production officer on board? No. This is a serious issue. If you don't flag it as health, nobody is going to flag it. That's why you have an outbreak of a disease in a community. The sub-county chief is just enjoying his motorcycle. The parish chief is not bothered. Why? Because you and me have not successfully put health as their business. So when we are designing community health interventions, please, let's look beyond look at the determinants of health to help us determine who should be the actors in community health interventions. How you do it requires a combination of politics, diplomacy, and technical knowledge. So I think we are very good on technical knowledge, but the politics and diplomacy need to be added on to what we do, let alone witchcraft.
What about players?
You'll be surprised how people think. Education is a big determinant of health. Big one. Whether someone finishes primary, secondary will determine whether he's going to vaccinate his children, whether the children are going to die at birth or not. These are very simple things. So if you are a DHO in a district, it costs you nothing once you come across issues of education, and then you put your heads together with the DEO. Works, environment. Health inspectors used to inspect houses. They are part of the approval process. But now what's happening?
The chiefs are the ones doing it.
So what are the competencies of a health inspector? A house which is poorly lit, a house which is poorly ventilated, a house which has got inadequate place, like here. This is not, this, have you read about sphere standards? Sphere standards. One person is supposed to sit at 3.5 square meter space. So where's the health inspector to run? Because there should be a carrying capacity of a hall. So these are determinants of health. If someone has his TB here, he will all go with those micro things. So living conditions and employment and so on, I'm not going to expand there. But the point is the determinants of health are outside the health sector, and for us to address it, we need to follow them to the source and harvest the required partnerships to drive that agenda to its logical conclusion. Individual lifestyles, Dugum explained to us. Now what it means is we need to make communities competent in these determinants of health so that they have initiative to do the right things, to do what is health. And this is, the other one is the obligation. The obligation of government is to provide the essential package, while the obligation or the responsibility of the citizen in the Constitution is to do what is required to keep healthy. One sentence, you read the Constitution. Citizens are supposed to do what is required of them to keep healthy. So we are only talking on the supply side most of the time. So when you enforce public health intervention, you're actually doing the right thing. There's no point in begging. Educate, educate, educate. Let the health educator educate. Enforce, enforce, enforce. Let the health inspector inspect. If you are doing it only talking, that's a joke. So let's be prepared to wait for the effect of our interventions longer if we are shy to enforce. Next. So there are many, many, many things. This is unpacking that slide to more detail. If you choose to ride on a boda, and the boda man is riding with one hand and sitting on one buttock, and you cannot say anything, if you are a boda, first of all, I look at you. You and me, our weight, can you manage? No. So if you are small, I don't sit on your bike. If you are there in Arua, it's people from Arua.
Yes.
If you are a border man and you are busy eating, you need external assistance to be awake. What were you doing when people were resting? So it means you're already sick. You need a neurostimulant to be awake on the motorbike. And I sit there. No. This is being competent. You don't need lectures about looking for a condom. It means you are incompetent. So, the ultimate result of our community health interventions is to build community competence where they will do things which promote health. Actions against these are health promotional interventions. Next. So the obligation on government is the package. I tried to get it off head, but it's longer than that. So, if that is the package, I'm hearing an advert that there are doctors who have come from India. They are doing operations for Brazilian butt lifting. Brazilian, and then the other one said, farm butt lifting. Whoever needs it, it's not my problem, but it's not part of our essential healthcare package. It's not an obligation on the government that your buttocks should be lifted up. Ours are interventions on reproductive health, communicable diseases, non-communicable diseases, outbreaks, and so on. And if government neglects you against that package, you can complain. If you are tired of the shape of your nose and you want it to be like this, I don't know for what, that is your business. It's not part of our essential healthcare package. Are we together? So, once you have, by the way, this package, as you will see later on the way forward, the package is delivered through those routes. If you are in health promotion and you are not in Ministry of Health, in the health sector, you are not promoting health, you are not preventing disease, you are not treating the sick, you are not rehabilitating, and you are not doing palliation. Maybe you too need assistance, because those are the interventions we have. They are cross-cutting for all the packages up there. And the platforms for you to work so far which are visible are those three. They are community platforms, they are school platforms, and facility platforms. Now you can unpack each of those platforms. Community, who are the key stakeholders? Please do not medicalize community health again. There's a wider scope. The others, you provide advisory service. You provide advisory. Do you know that the British, in your village, land is measured by farmers in quarters? Huh? Yeah, I planted 2 quarters of beans. Do you know where that quarter thing is coming from? It was the unit for measurement for production. The British would come and through the sub-parish chief ask, how many children do you have? What is the family size? I have 12. Okay. From our study, the productivity of the soil here is 4 bags per acre. And one bean, the kilograms needed by one person in a year is this. And therefore you require these bags. And then they work the bags backwards to the land which can give you those number of bags. This is the science. So, and this is how you address food security. Not a workshop issue. These days people sit and they are eating chicken and then talking food security. That will not take us far. Food security is at the community, and you must apply your knowledge of productivity, of nutrition, through the community structures, put that knowledge in the hands of households and families to make health. Next. Our health systems are weak to deliver community health services because we have not invested there. I love that picture. That is my first banana I've ever planted, and that is in Koboko. That banana became so huge that I had to support it. Most of us say we're doing health system strengthening, but we are actually doing health system support. And when you remove that stick, what happens to that banana? Aha! The reason why we will be pumping money through this project, that project, we change the name, we change the address, we change the logo, we call it Chezo. Because we are supporting the system. After pumping all those resources, when the resources disappear, the system cannot function. Ladies and gentlemen, we're Ugandans. Let's also leave things which will live for posterity. Now, give me the next slide. This picture, I took it on the Pennsylvania Avenue in Washington. They made this statue and wrote somewhere, make no little plans. When you are strengthening a system, this man, if he climbed, you see that horse? You see the meat on it? If this man came out from a ward and decided to climb on this horse, what would happen? So the community health work we are doing is a big business, and it requires us to build the muscles to face it. So therefore we need to adopt systems strengthening approaches to fight this battle ahead of us. Now I'm going to give you next. We know this very well. The moment you invest on service delivery block up there, you are supporting, and it is a vertical program. If I give you advice that you don't listen, I save my energy. You go verticalizing. If you create focal points for condom, for family planning, you go another one for breastfeeding, another one for butt lifting, go ahead. The system will remain weak. You will have changed the appetite of the health system to something else, and when you go, you leave it confused. If you are putting your money on human resource, on information systems, on supplies, financing operations, and building leadership capacity, you are supporting the system. There is no nurse who is trained as a family planning focal person. You will make him a specialist in family planning. She has lost her entire safe motherhood chain. Please, when we say integrated services, we're not asking too much. I don't want to go through this. So that we increase access, we increase coverage, we address safety, we address quality. Next slide. The helicopter is now landing. Is it this one? Is it this one? Do you move to the next slide, I see? Yes. That one is crowded. It doesn't matter how beautiful your strategy is. if you do not address these things systematically. For the health workers will require tools, but the tools require skills. Skills require staff and structure, and the infrastructure. And you deploy those on structures, roles, and systems, and you should also be cognizant of the local context. In this way, you understand that the cognizance of local context will help you move back to the tools. So when we are going to the implementation level or developing guidelines, let's pay attention to these details. Next. That is the slide you asked me to do. I looked at, if you want community health work to take root, the other structures up are important, but they will not give us the result we need if we don't focus downwards. So, the health center 4, some of us still are nostalgic about health sub-districts. At the health sub-district level, you have teams who are there to support, community health work. There is a position of senior environmental health officer, environmental officer, health educator, nursing officer, public health. Those are the nurses with the blue uniform. I don't know where they are nowadays, and whether they are being produced. Assistant nursing officer. These positions now exist in the health center 4 structure. And assistant nursing officer in health, the brown one, those positions are in health center 3. The village health teams, the community health extension workers, we are not going to post them to work the way an enrolled nurse is posted to a health center and manages herself. You post the health center to that staff to a health center too, and he's on autopilot. Knows how to draw a program. In the morning, he knows that I must open, I must sterilize, I must report. No. The community health workers will need to be assisted throughout the process. And there must be technical backstopping by a group. Now, this cadre, whom we have carefully put in the structure, you have the health educators who must do health education, support health education at the community level, to support health promotion, to have action on determinants of health. You also have the health inspectors and health assistants. They are there to ensure that they inspect. After inspecting, they enforce. Ugandans don't want enforcement. That's why a boda can now carry 5 people, others facing backwards, others this way, and nobody is complaining. And we are defining a new normal because of lack of enforcement. Ladies and gentlemen, there is no alternative to enforcement. I was in a place in the UK, I saw somebody wrote there and said, dog droppings not allowed here. I said, this is serious. The dog must not defecate here. Then I saw a man walking with his dog, and the dog had a nappy on its bums. I said, if in Europe they can enforce dog droppings to a point where a dog wears a nappy, we cannot enforce reckless riding? No, there's something wrong. And it is the health educator who must talk about it. Our community health actors must talk about it. Are we okay? So, the health educator, the health inspector, then you have the public health nurse who have to deal with the maternal child health component at the community level. These can now backstop the CHUs and VHTs, who are also carefully selected to do these different works. So I concluded by saying that the business we have started is big, because if you look at the fourth last column, those are the numbers I was able to reach through the Human HR Audit report. We have about 3,000 health assistants. We have 147 health educators in the whole country, 60 assistant health educators. These numbers cannot impact community health program. If we're in this room in the names of community health program, to take action on determinants of health, the starting point is ensuring that you have a critical mass of people who can drive this agenda at this constituency level and at the sub-county level. The document talks about Health Center 3, but I think that's the placeholder. They function better, even if they sleep in the Health Center 3, when you organize their work around sub-counties. So, as I speak, if you start from the professionals and you add the village health teams, and CHUs, we need about 21,000 CHUs, we need about 141 VHTs, and we need about 10,000 health assistants, and that number will make us busy. Next slide. So going forward, two things. A strategy will not save us unless we address the issue of structure, the strength, the support, the skills, and the tools. That's what I've been talking in many words. Find those 5 things. So moving forward, we need to integrate community health interventions. I don't see an alternative to it. How do we integrate? We must make use of the strategy and change the way we write proposals to reach households with a package of services. That's what it is saying. One community health strategy and a plan is the beginning point. Without it, the resources attracted for health services will be a tool of terrorism. When a bundle of dollars is dropped here, this meeting will go into confusion. Because we're all going to scramble for it. So when you have resources which are not channeled through an agreed plan, it will create stampede. And I don't think there's a WHO who needs that. Can you agree with me? We have been at this thing for some time. So, one plan. Now, once you have agreed on the plan, the next thing is to align partnerships. Which means your proposals must derive from the strategy. What are the objectives? Which objective am I feeding into? So you must be informed by the strategy. Otherwise, the strategy will be a document which will accumulate dust. Pick your proposals from the strategy. The activities which you plan to avoid wastage, you can agree. Are you implementing a component of one activity, or are you going all over the country, or are you going to a certain block? You map yourself so that you address access, which is a rights issue, equity, leaving nobody behind, so that you have adequate coverage. Once you do that at the conceptual level, the third thing is to pool resources. Pooling resources does not mean you give the money to a vendor. You can do virtual pooling. You can hold your money. The best